1, 2,
And review, somebody female.
Oh shit, I got some blood going. Oh, he's wearing it too.
You're in the bay. Once you get over to the bed, we'll give you the story. Everything's going to happen super fast. Welcome to the emergency room.
I lost the pulse.
It's
300 please.
I'll keep you on guard again.
Pulse check. No pulse.
no more pulse.
Yeah. Where the echo people get? And her blood pressure is off the dropping.
45 minutes of CPR and no return of circulation. Okay.
You know, usually when we talk about a medical diagnosis, there's this expectation of precision. It feels like engineering.
Right, yeah.
Someone breaks their arm, the x-ray shows that jagged white line, and the doctor just points at it and says, there it is.
It's binary. I mean, it's either broken or it's not.
Exactly. It's clean.
Yeah.
And it's comforting because we like things to be visible, neatly categorized in a little box. But then you step into the intensive care unit.
Oh, yeah. Completely different world.
Right. You step into the world of critical respiratory failure, and suddenly that pristine x-ray machine doesn't give you the whole picture at all.
Mm-hmm.
We are looking at a diagnostic landscape that is honestly just completely murky.
It is the absolute definition of diagnostic muddy waters. And frankly, that is the reality of critical care. You don't always get the luxury of a perfect, clear-cut image.
Which is exactly why we're putting ourselves in a very specific headspace for this deep dive today.
Okay.
You are a critical care nurse. You are standing at the bedside in the ICU. Alarms are going off all around you, and you are staring at these muddy waters.
Yeah, you're right in the thick of it.
We are looking at lower respiratory tract diseases strictly through the lens of an elite ICU intensivist.
Mm-hmm.
We aren't going to read a textbook list of like every possible symptom for every possible pulmonary disease.
No, absolutely not, because that doesn't help you at 2 a.m. when your patient is actively decompensating. We are aggressively applying the Pareto principle here.
Yeah, 80-20 rule.
Exactly. We are focusing on that vital 20% of information that dictates survival, that drives exam performance for those of you mastering this material, and most importantly, that guides those split-second bedside decisions.
So if I'm at the bedside, how do I actually build that intensivist mindset? Like, how do I filter out the noise?
You have to follow a very specific mental framework, this cascade of logic. You look at the patient and trace this line. You ask, what is the problem? How is a physiologist failing because of it?
Okay, problem. Failing physiology.
Right. Then, what is the immediate life-ending threat? What is my intervention? And finally, reassessment. So, problem, physiology, threat, intervention, reassessment. If you can trace that line backwards and forwards, you can manage any patient in that bed.
I love that. I want to use an analogy to ground this because the respiratory system isn't just a pair of balloons. It's more like a highly complex, high-tech engine.
I like that a lot. Let's build the engine.
Okay, so first you have the fuel injectors. Those are the alveoli, the microscopic sacs where the actual gas exchange happens. Then you have the mechanical bellows, so the chest wall, the ribs, the pleural space, that physically create the vacuum to pull the air in.
Right, the pump itself.
Exactly. Then you've got the fuel lines, which is the pulmonary vasculature, bringing unoxygenated blood to pick up the oxygen. And finally, the exhaust system, getting rid of the carbon dioxide.
So if we look at respiratory failure through this lens, we are essentially looking at what happens when each of these individual components catastrophically fails.
And if we are starting with catastrophic failure, we have to start at the microscopic level. We have to start with the fuel injectors.
Right, the alveolar flood. We're talking severe pneumonia and massive infectious threats.
But here's the thing that always trips people up. If acute bronchitis is just, the inflammation of the major airways and something like pertussis is damage to the cilia, why does pneumonia suddenly plunge a patient into acute respiratory failure so fast?
Well, because it attacks the actual site of gas exchange. Bronchitis is a traffic jam in the transit tubes, but pneumonia is a bomb going off right at the destination.
Oh, wow.
Yeah, just to frame the scope of this, pneumonia, whether it's community-acquired, hospital-acquired, ventilator-associated, or an opportunistic infection in an immunocompromised patient, it is an acute infection of the lung parenchyma, and it is the 4th leading cause of death worldwide.
So let's trace that physiology. Trigger, physiologic change, compensation, decompensation. What's actually happening inside that tiny microscopic sac.
It almost always starts with a trigger, usually the patient inhaling a pathogen or microaspirating their own oral flora, so the bacteria land in the alveoli. The body's immune system senses the invader and triggers a massive inflammatory response.
Oh.
Cytokines are released, and neutrophils rush to the site to fight the infection.
Which sounds good, right? Like the immune system is doing its job.
It sounds good until you look at the collateral damage. Those inflammatory mediators cause a massive increase in capillary permeability.
Meaning they get leaky.
Exactly. The blood vessels surrounding the alveoli literally become leaky. Because of that leak, protein-rich fluid, red blood cells, and cellular debris pour out of the capillaries and dump directly into the alveoli.
So the fuel injector is flooding.
Completely underwater. The alveoli, which should be filled with nothing but air, fill with this thick inflammatory sludge. This is what we call consolidation. Now think about the blood flow. You have unoxygenated blood traveling through the pulmonary capillary, driving past an alveolus that is completely consolidated. No oxygen can possibly cross that thick membrane of sludge.
It's just driving past a closed factory.
Exactly. This is called shunting. The blood is moving, perfusion is happening, but gas exchange is zero.
Yeah.
That unoxygenated blood mixes right back into the left side of the heart and gets pumped out to the body, leading to profound systemic hypoxia.
So as the nurse at the bedside, my assessment is going to reflect that hypoxia. Early signs would be tachypnea, the body trying to breathe faster to compensate.
Right.
Maybe a fever from the immune response, pleuritic chest pain, and a productive cough.
Yes, and that sputum will often be rust-colored, green, or yellow, depending on the specific pathogen. If you put your stethoscope on their chest, you are going to hear fine or coarse crackles as the air bubbles through that fluid.
Okay.
And if there's dense, solid consolidation, you'll hear egophony.
That's where you have them say E, but through the stethoscope it sounds like A, right?
Spot on.
Because sound travels differently through a solid mass of sludge than it does through air.
Exactly. But we need to talk about the late dangerous signs, specifically in older adults, because this is a massive clinical trap.
Because their immune system doesn't mount that textbook response we expect.
Precisely. The aging immune system totally masks the classic presentation. In an 80-year-old patient, you might not see a fever at all. In fact, they might present with hypothermia.
Wait, really? Hypothermia?
Yes. They might not even have the strength to produce a cough. The only initial sign you might get is a sudden, drastic change in mental status, confusion, agitation, or stupor.
Let's connect that to the physiology. Why the confusion?
Because the brain is the most oxygen-hungry organ in the body. If the alveoli are flooded and shunting is occurring, the brain is quite literally starving.
So it's not dementia acting up?
No, if you see an elderly patient who is suddenly confused and breathing fast, you cannot just assume it's a UTI or sundowning. You must immediately think hypoxia from pneumonia.
That completely changes how I'd look at an altered mental status. It's not just delirium, it's literal suffocation.
Right.
So, we suspect pneumonia. We are running diagnostics. Chest x-ray will show the consolidation. Arterial blood gases will show hypoxemia. But let's talk about the labs and the cultures, because the timing here is a huge priority.
Yeah, the white blood cell count will likely be spiked over 15,000 with a left shift.
Needing lots of immature bands, right?
Yes, indicating a severe bacterial fight. We also look at inflammatory markers like C-reactive protein and procalcitonin, but the absolute crux of your diagnostic priority is the sputum culture and gram stain.
Because we need to know exactly what bug we are fighting so we can target it.
Yes, ideally. You want to capture the pathogen before you introduce antibiotics that might skew the results. But here is the intensivist rule, the thing that dictates survival.
Okay, I'm listening.
Never delay empiric antibiotic administration if a specimen cannot be gathered quickly. If the patient is dry and can't cough anything up, you do not wait. Delays in empiric antibiotics directly increase mortality.
Okay, so let's rank our interventions for the bedside. What is the very first thing I'm doing in ADPIE?
The highest priority problem is impaired gas exchange. So first, you oxygenate, apply O2, and mechanically elevate the head of the bed to at least 30 degrees to drop the diaphragm and maximize lung extension.
Makes sense.
Then XT, you get your cultures, sputum and blood cultures if they are hemodynamically unstable. Then you administer empiric broad-spectrum antibiotics within hours of presentation.
Let's dig into those medications. Why are we choosing specific drugs?
Empiric therapy means casting a wide net. For a community-acquired case, we typically use macrolides like azithromycin, beta-lactams, or respiratory fluoroquinolones.
Why those specifically?
We use these because they cover the most common typical and atypical pathogens.
But what if this is a hospital-acquired infection? Or, say, they've been on a ventilator for a week?
Then the threat landscape changes entirely. Now we have to worry about highly lethal, multidrug-resistant organisms. If we suspect MRSA, we immediately reach for vancomycin or linezolid.
And for Pseudomonas?
If we suspect Pseudomonas, we need a heavy-hitting anti-pseudomonal beta-lactam. We pull out the big guns immediately because if we guess wrong and undertreat, the patient rapidly progresses to acute respiratory failure and septic shock.
Here is something that seems contradictory to me. We know there is thick, gross sludge in the lungs. Intuitively, I think we want to hydrate them aggressively with IV fluids to thin out those secretions so they can just cough them up. But is that safe?
This is where you have to think like an intensivist and look at the whole patient, not just the lungs.
Okay.
Yes, hydration thins secretions, but you must enforce strict intake and output monitoring. Let's say your pneumonia patient also has a history of congestive heart failure.
Right.
Their heart is already a weak pump. If you aggressively bolus them with IV fluids to thin their lung secretions, that weak heart can't handle the volume. The fluid backs up, the hydrostatic pressure in the pulmonary capillaries skyrockets, and you push them right into pulmonary edema.
So I fix the sludge, but I drown the patient in their own fluid.
Exactly. It is a razor-thin tightrope.
That is wild. Okay, let's talk pattern recognition. How do I know I'm not looking at something else?
Well, if the patient has a terrible cough, but the chest x-ray is totally clear, their sputum is clear, and you don't hear crackles or see consolidation, think acute bronchitis.
Okay, so no consolidation.
Right. It's usually viral, it's self-limiting, and antibiotics are completely useless.
And what about pertussis?
Pertussis is caused by a gram-negative bacteria, Bordetella pertussis, that actively destroys the cilia in the respiratory tract. It starts like a mild cold, but turns into uncontrollable, violent coughing fits with a high-pitched whoop sound on inspiration.
And how long does that last?
It can last for 6 to 10 weeks. They need macrolides and strict droplet precautions.
Okay, before we move on to the next threat, I want to make sure I've got my mental checklist straight for pneumonia. Let's lock in our 5 things summary.
Sounds good.
Okay, so the core patho is that inflammatory exudate causes alveolar consolidation, leading to massive shunting. My key assessment is tachypnea, crackles, and I'm hypervigilant for confusion in my elderly patients. The worst complication is respiratory failure and sepsis. My priority is to oxygenate and get cultures, but I am never delaying those empiric antibiotics.
That is the exact clinical picture. If you see a febrile tachycardic patient with a productive cough, crackles, and a new X-ray infiltrate, that's your alveolar flood.
Awesome.
And the golden rule to remember, if you see new confusion in an elderly patient with tachypnea, you immediately think hypoxia from pneumonia, apply O2, and grab an ABG.
Perfect. So we've seen what happens when the fuel injectors simply fill with fluid. But what happens when a pathogen doesn't just occupy the space, but actively eats the tissue? We are moving from the acute flood to the stealthy chronic destroyers, tuberculosis and lung abscesses.
Yeah, while pneumonia drowns the tissue, TB and abscesses hollow it out. The 80-20 overview here is about chronic cavitary destruction. Tuberculosis is caused by Mycobacterium tuberculosis, which is an acid-fast bacillus. A lung abscess is a necrotic cavity usually caused by the aspiration of anaerobic oral flora. Both essentially destroy the lung tissue.
Walk me through the TB pathophysiology, because this bacteria has a fascinating, if terrifying, survival mechanism.
It is incredibly insidious. TB is airborne. A person exhales, and the bacteria travel in tiny droplet nuclei. Because they're so incredibly small, when another person inhales them, they bypass the mucus, bypass the cilia, and lodge deep in the terminal alveoli.
And the immune system responds just like it did with pneumonia.
It tries to, but Mycobacterium tuberculosis has this waxy cell wall that makes it incredibly resistant to being destroyed by macrophages.
Oh, so the macrophages can't digest it.
Right. The immune system realizes it can't kill the invader easily, so it opts for containment. It builds a literal wall of macrophages, T cells, and fibrous tissue around the bacteria. This walled-off fortress is called a granuloma, or a Gone lesion.
It just builds a prison around the bacteria right in the lung?
Yes. And inside that prison, the bacteria can lay dormant for years, even decades. That is latent TB.
And are they contagious then?
No, the patient is not sick, and they are not contagious. But, and here's the decompensation, if the patient's immune system ever weakens due to HIV, severe stress, high-dose steroids, or malnutrition, the guards at the prison basically fall asleep.
And the bacteria break out.
Exactly. The bacteria replicate, break out of the granuloma, and begin actively digesting and destroying the lung parenchyma. That is active TB.
And what about the lung abscess? How does a cavity form there?
It usually starts with an unconscious patient. Maybe they're intoxicated post-seizure or just have a poor gag reflex, and they aspirate their own oral flora deep into the lung. Because these are often anaerobic bacteria, they cause a slow-burning, festering infection. Over weeks, this infection causes necrosis. The lung tissue dies and liquefies, creating a cavity filled with highly purulent, terribly foul-smelling fluid.
So the assessment for these two has to be completely different from a patient who crashes overnight with acute pneumonia.
Very much so. TB is a disease of chronic wasting. The classic early assessment is a dry cough that slowly, over winks, turns purulent. They will have profound night sweats, unexplained weight loss, and a low-grade fever, usually hitting in the late afternoon.
How do you know the patient is dangerously deteriorating?
You know they are deteriorating if you see hemoptysis, coughing up blood.
Because the bacteria have literally chewed through the lung tissue and eroded into a pulmonary blood vessel.
Exactly. Or they develop sudden severe dyspnea, indicating the lung is failing entirely. Now, for the abscess assessment, the hallmark is the sputum. It is dark brown, foul-smelling, and sour-tasting.
Ugh, that sounds awful.
It is. The patient will have pleuritic pain, and if you percuss over the cavity, it will sound dull with decreased breath sounds.
Let's talk diagnostics. I know TB can be really tricky to confirm.
Well, the absolute gold standard is the sputum culture, but mycobacterium grows incredibly slowly. It can take up to 6 weeks to finalize.
6 weeks. You can't wait 6 weeks to treat or isolate a patient.
Exactly, you absolutely cannot. So we rely heavily on AFB smears, acid-fast bacillus smears. We need 3 consecutive morning sputum specimens. We also use IGRA blood tests, like the quantiferon gold.
Why are those better than the old skin tests?
They are fantastic because they are fast, and unlike the PPD skin tests, they aren't affected if the patient previously had a BCG vaccine. A positive PPD only means exposure or antibodies, not necessarily active disease.
Right. And for the abscess.
A chest x-ray is usually definitive. You will literally see a single cavitary lesion with a straight line across it. That's the air fluid level inside the cavity.
So ADPIE and priority actions. If I suspect my patient have active TB, what is my absolute first move?
This is a massive safety priority. First, that patient must immediately go into airborne infection isolation.
Negative pressure.
Yes, a negative pressure room, and every single person entering that room must wear a fit-tested N95 or a PPR respirator.
Good.
Do this before you draw blood, before you get a full history. Contain the airborne threat first.
And then
next T, collect your sputum specimens. Then, prepare the patient for long-term medication administration, which often requires DOT or directly observed therapy by a public health nurse.
Always unnecessary.
To ensure they don't stop taking the meds early and create a mutant drug-resistant strain, it's a huge public health issue.
Which brings us to the medications. TB is notorious for its brutal drug regimen.
It really is a marathon. Active TB requires a 4-drug-intensive phase for the first 2 months to hit the bacteria from every angle. We use the mnemonic RIPE, rifampin, isoniazid, pyrazinamide, and ethambutol.
Isoniazid and rifampin are the heavy lifters there. What is the physiological mechanism and the nursing priority?
They disrupt the cell wall and RNA synthesis of the bacteria, but the major life-threatening adverse effect of isoniazid, rifampin, and pyrazinamide is severe hepatotoxicity.
They wreck the liver.
They are brutal on the liver. You must monitor liver function tests, AST and ALT, religiously. If they start developing jaundice or dark urine, you have a major problem.
And there's a classic exam parole regarding rifampin, right? Something about body fluids.
Yes, this is always tested. Rifampin will turn all body fluids, urine, sweat, tears, saliva, a bright reddish-orange color. It is harmless, but if you don't educate the patient beforehand, they will think they are sweating blood and completely panic.
I would panic too. And for the lung abscess medication, are we using RIPE?
No, we aren't using RIP for an abscess. We use IV clindamycin because it has excellent tissue penetration and broad coverage against those anaerobic bacteria.
What are the complications we are watching for as these cavitary diseases get worse?
For TB, the most terrifying complication is miliary TB.
What's that?
This is when the bacteria erode into the bloodstream and disseminate throughout the entire body. seeding granulomas in the brain, the liver, the bones. It is highly fatal. For an abscess, the cavity can grow so large that it ruptures into the pleural space,
causing an empyema.
Exactly. A massive pocket of pus around the lung, or a bronchopleural fistula.
There's an ICU trap here regarding chest physiotherapy that honestly blew my mind when I read it in the prep materials.
Oh, yes. This is a crucial one. If a patient has a lung abscess, you might think, hey, let's do chest percussion and postural drainage to help them cough up that fluid.
Right. Wouldn't getting the pus out be a good thing?
Never do that. Think about the anatomy. You have an isolated, necrotic cavity full of billions of anaerobic bacteria. If you mechanically pound on that chest, you can dislodge that fluid.
Oh, no.
It spills out of the cavity and floods down into healthy, pristine adjacent bronchi or entirely different lobes. You take a localized infection and turn it into massive bilateral necrotic pneumonia. You could kill them.
Wow. Okay. Leave the toxic waste dump contained until the antibiotics can neutralize it. Okay, let's lock in the 5 things summary for this section. Patho is bacillar walled-off and granulomas or creating necrotic tissue cavities. Assessment is night sweats, weight loss, hemoptysis, and foul sputum for the abscess. The ultimate threat, the worst complication, is miliary dissemination or massive hemoptysis. My absolute priority is immediate airborne isolation for suspected TB, followed by multi-drug therapy with strict liver monitoring.
Spot on. If you see an immunocompromised or high-risk patient presenting with chronic night sweats, weight loss, and hemoptysis, think highly contagious airborne pathogen and get them into a negative pressure room and don an N95 mask immediately.
All right, so we've dealt with the lung tissue itself, the fuel injectors drowning in fluid or being chewed apart. But what if the lungs are totally fine? What if the mechanical box holding them, the ribs and the pleural space, is completely destroyed?
This is where we shift from infectious diseases to restrictive mechanical disorders. The lungs just can't inflate if the box is broken.
So the bellows are crushed.
Exactly. We are looking at blunt and penetrating trauma resulting in flail chest, hemothorax, and the absolute king of ICU emergencies, the tension pneumothorax.
Let's do a deep dive into the tension pneumothorax pathophysiology, because this is one of those terrifying scenarios where a respiratory problem actually kills you via the cardiovascular system.
It is a masterpiece of failing physiology, and it happens incredibly fast. Here is the cascade. You have a laceration in the lung or the chest wall, maybe from a fractured rib or a stab wound. This creates a one-way flap valve in the pleural space.
So on inspiration, the chest expands, creates negative pressure, and sucks air through that laceration into the pleural space.
Exactly. But on expiration, the positive pressure pushes that tissue flap closed. The air cannot escape.
So every single breath they take traps more and more air.
With every breath, the pressure in the pleural space rapidly increases. It completely collapses the lung on that side. But it doesn't stop there. The pressure gets so high that it literally pushes the entire mediastinum, the heart, the trachea, the great vessels, shoving them forcefully toward the opposite, uninjured side of the chest.
And here's where it turns lethal, right? As the heart is shoved over, it physically kinks and compresses the superior and inferior vena cava.
Precisely. The blood trying to return to the right atrium hits a wall. Venous return plummets to near zero. Think about Starling's law of the heart. If there is no preload, no blood entering the heart, there is no cardiac output. The heart is beating empty, the blood pressure tanks, and the patient rapidly spirals into obstructive shock and cardiac arrest.
And what about flail chest? How does a broken box cause hypoxia there?
Flail chest happens when massive blunt trauma fractures 3 or more adjacent ribs in 2 or more places. You literally have a free-floating segment of the chest wall.
That sounds incredibly painful.
It is, but the mechanical failure here is called paradoxical movement. Normally, when you breathe in, the diaphragm drops and the chest wall expands outward, right? But with a flail segment, when the patient breathes in, the negative intrapleural pressure sucks that broken, floating segment inward, directly crushing the lung beneath it.
And then on expiration?
On expiration, when the rest of the chest recoils, the positive pressure makes the flail segment bulge outward. The bellows are completely out of sync, leading to severe hypoventilation, retained CO2, and hypoxia.
So how do we spot these mechanical failures at the bedside before the patient codes? What's the assessment?
Early signs of any major chest trauma are severe dyspnea, tachycardia, and asymmetric chest movement. But for a tension pneumo, the specific signs are extreme agitation, subcutaneous emphysema.
Which feels like bubble wrap crackling under the skin of their chest and neck. Right?
Yes, exactly like bubble wrap. You'll also find absent breath sounds on the affected side because the lung is compressed to the size of a fist, and hyperresonance when you percuss because you're tapping on a drum full of highly pressurized air.
What tells the nurse the patient is actively dying? What are the decompensation signs?
Severe precipitous hypotension, profuse diaphoresis, and massive jugular vein distension, or JVD, because the blood from the head hits that kinked superior vena cava and backs up into the neck veins. And I want to point out a huge clinical trap here.
What's the trap?
Textbooks always talk about tracheal deviation, the windpipe shifting away from the affected side.
Right, that's the classic board question sign. Everyone learns that.
It is, but listen to me carefully. Tracheal deviation is a very late near-death sign. If you wait at the bedside to see the trachea shift before you intervene, you're going to be packing that patient in a body bag.
Oh, wow. So if I see the severe dyspnea, absent breath sounds, and dropping blood pressure, what is my escalation? Do I call the doctor for an order?
No. Attention pneumothorax is not a call the provider and wait for orders situation. It is an immediate code or rapid response medical emergency. First, immediate needle decompression.
You don't even wait for a chest x-ray.
You don't even wait for an x-ray. A provider will take a large bore needle and insert it into the second intercostal space at the midclavicular line to vent the trapped air. You will literally hear a loud hiss of air escaping, and because the vena cava unkinks, the blood pressure will instantly rebound.
That is incredible.
It's life-saving. And next, you prepare for a definitive chest tube insertion connected to a water-sealed drainage system.
What if it's an open pneumothorax? Like a gunshot wound where air is just sucking in from the outside.
You have to stop the air from entering, but you can't seal it completely or you'll create a tension pneumo inside.
Oh, right, because then the air can't get out either.
Exactly. You immediately cover the wound with a vent dressing, a non-porous, occlusive dressing taped on only 3 sides. This acts as an artificial one-way valve. It allows trapped air to escape out from under the untaped edge on exhalation, but sucks flat against the skin on inhalation to prevent more air from entering.
Let's talk procedures.
Yeah.
If we put a chest tube in, and later they keep having recurrent pneumothoraxes or pleural effusions, how do we fix the box permanently?
We use a procedure called pleurodesis. We instill a chemical slurry, often sterile talc or a sclerosing agent, directly into the pleural space through the chest tube.
Yeah, baby powder.
Sort of, yes, sterile medical talc. The goal is to intentionally cause intense, painful inflammation. We then clamp the chest tube for 8 hours and physically roll the patient from side to side to coat the entire cavity. The inflammation causes the visceral pleura on the lung and the parietal pleura on the chest wall to violently scar and fuse together.
So it glues the lung to the chest wall.
It permanently obliterates the pleural space so fluid or air can never collect there again.
Are there any nursing traps with these chest trauma patients? Things we might do that make it worse?
2 massive ones. First, for rib fractures, never completely strap or bind the chest tight.
But wouldn't splinting it make it hurt less?
It feels intuitive to splint it so it doesn't hurt, but if you restrict chest expansion, they can't take a deep breath. They will develop atelectasis and a deadly pneumonia within 48 hours. Manage their pain with epidurals or nerve blocks so they can breathe.
And the second trap?
Clamping a chest tube. If a patient has an active pleural air leak and you clamp their chest tube, say you're changing the drainage system, the air has nowhere to go. You will literally cause an iatrogenic tension pneumothorax within minutes.
That is terrifying. Okay, checking my 5-thing summary for the crushed bellows. Patho is the loss of negative intrapleural pressure collapsing the lung and the mediastimal shift compressing the vena cava. Assessment is absent breath sounds, JVD, and paradoxical movement for flail chest. The ultimate threat is obstructive shock and cardiac arrest.
Right.
My priority is to relieve that pressure immediately, and the treatment is needle decompression and chest tubes.
Exactly. If you see a trauma patient with severe dyspnea, JVD, and a rapidly dropping blood pressure after chest trauma, think tension pneumothorax and DO, prepare for immediate needle decompression.
Okay, so we've fixed the bellows, the injectors are dry, but here is a terrifying scenario. The chest wall is expanding perfectly, the alveoli are totally clear, but the patient is suffocating and turning blue. Why? Because the blood never arrived to pick up the oxygen.
Right. We're moving from the mechanical bellows to the fuel lines, a complete vascular blockade.
We are talking about pulmonary embolism and pulmonary edema.
Yes. The 80-20 overview here focuses on massive disruptions to the VQ match, ventilation, and perfusion. A pulmonary embolism, or PE, is a physical, solid blockage of the pulmonary arteries. Usually it's a piece of a thrombus that broke off from a DVT, but it can be fat from a fractured femur or even an air bubble from a central line.
And pulmonary edema.
Pulmonary edema, conversely, is fluid backing up from left-sided heart failure. Both completely destroy gas exchange, but from totally different mechanisms.
Let's walk through the PE pathophysiology step by step. Where does the clot come from, and how does it actually kill you?
Almost always, it starts with a deep vein thrombosis in the deep veins of the leg or pelvis due to immobility, surgery, or hypercoagulability. The clot breaks loose, it travels up the inferior vena cava, flows right through the wide-open right atrium and right ventricle, and gets pumped forcefully into the pulmonary arterial tree.
And it gets stuck.
As the pulmonary vessels branch and get smaller, the clot inevitably wedges. If it's a massive clot and it lodges right at the main bifurcation of the pulmonary artery, it's called a saddle embolus, and it is often instantly fatal.
So what happens physiologically to the lung tissue past the clot?
The clot completely obstructs blood flow to alveoli that are perfectly ventilated with fresh oxygen. So you have V but no Q, ventilation without perfusion. This creates massive alveolar dead space.
The oxygen is there, but there's no blood to pick it up.
Right, leading to severe hypoxemia. But the real lethal threat is hemodynamic.
To the heart.
Yes. The right ventricle is now trying to pump blood against a literal brick wall. The pressure in the pulmonary arteries skyrockets. The right ventricular muscle stretches and strains against this massive afterload. It dilates rapidly, the septum bows into the left ventricle, and the right heart simply fails.
Assessment. How do we catch this?
The early signs are incredibly sudden. Sudden onset of unexplained dyspnea, mild to moderate hypoxemia, tachypnea, tachycardia, and pleuritic chest pain. The patient will often be anxious and restless.
And the dangerous deterioration. The sign they are crashing.
A sudden change in mental status, profound hypotension, syncope, and a very classic, very real symptom. A severe feeling of impending doom.
I've heard about that. They actually know they're dying.
The patient will grab you and tell you they're going to die. This is a physiological response to massive neurohormonal release and cerebral hypoxia. Listen to them. 10% of massive PE patients die within the first hour due to cardiogenic shock from that right ventricular failure.
Diagnostics. How do we find the clot?
The absolute gold standard is the spiral or helical CT angiography. It uses IV contrast to give us a beautiful 3D view of the pulmonary vasculature, and you can literally see the dark blockage in the bright white vessel.
And if they can't have contrast?
If the patient has severe renal failure and can't take the contrast dye, we do a VQ scan to look for mismatched areas of airflow and blood flow.
I always hear about the D-dimer blood test for blood clots. How reliable is that?
This is a massive exam trap. A D-dimer measures fibrin degradation products, the trash left over when the body tries to break down a clot. Here is the rule. A normal negative D-dimer is highly sensitive and can confidently rule out a PE.
Okay, so if it's negative, we're clear.
But an elevated D-dimer does not confirm a PE. Why? Because it is not specific. Any inflammation, recent surgery, trauma, or even pregnancy can elevate a D-dimer. You cannot diagnose a PE based solely on an elevated D-dimer.
Okay, so ADPIE and priority actions for a suspected PE.
First, apply high-flow oxygen, elevate the head of the bed, and do a rapid cardiopulmonary assessment. Next T. Establish large-bore IV access and monitor continuously for signs of shock. Then initiate immediate anticoagulation therapy.
Let's get into the pharmacology, because this is where the treatment pathways split, right?
Yes. Subcutaneous low molecular weight heparin, like enoxaparin, is the preferred initial treatment for stable patients over unfractionated IV heparin.
Why is it preferred? What is it doing differently?
Unfractionated heparin has a very unpredictable pharmacokinetic profile. It binds to plasma proteins randomly, which is why you have to constantly draw blood for APTT monitoring and adjust the drip.
Oh, that makes sense.
Low molecular weight heparin is a smaller fractionated molecule. It has a highly predictable dose-response curve, lasts longer, and doesn't require constant blood monitoring. It's much safer. We also start oral warfarin early for long-term management, monitoring their INR.
But wait. Heparin and warfarin are just anticoagulants, right?
Yeah.
They just stop the clot from getting bigger. What if the patient has a massive saddle embolus, their blood pressure is 60/40, and they are actively dying from right heart failure?
Excellent point. If they are hemodynamically unstable, anticoagulation isn't enough. You must use fibrinolytics, like TPA.
Tissue plasminogen activator.
Yes. Fibrinolytics actually go in and chemically dissolve the existing clot, restoring blood flow immediately. The risk of catastrophic bleeding is high, but they will die of shock without it.
What if they just had brain surgery and can't have TPA or heparin?
Then we go to procedures. We might do a surgical embolectomy to physically cut the clot out. Or we insert an inferior vena cava, or IVC filter. It looks like a little metal umbrella placed in the vena cava. It won't fix the current clot, but it catches future clots from the legs before they can reach the lungs.
And how do I differentiate this from pulmonary edema? You said they both ruin gas exchange.
They both cause extreme shortness of breath and hypoxia. But pulmonary edema is fluid backing up into the alveoli from a failing left heart. The hallmark assessment is frothy, pink, blood-tinged sputum and severe crackles.
So the treatments are totally different.
Completely. Giving heparin to a pulmonary edema patient does nothing. Pulmonary edema requires preload reduction, diuretics like furosemide to pee the fluid out, and vasodilators like nitroglycerin to relax the vessels. PE requires clot management.
Okay, locking in the 5-thing summary for the vascular blockade. Patho is a thrombus blocking pulmonary blood flow, causing massive VQ mismatch and right ventricular strain. Assessment is sudden dyspnea, tachycardia, and a feeling of impending doom. The complication is right ventricular failure and cardiogenic shock.
Right.
Priority is to oxygenate and stabilize hemodynamics, then treat with anticoagulation or fibrinolytics if they're crashing.
You got it. If you see a postoperative or immobilized patient who suddenly grasps their chest, gasps for air, and feels an overwhelming sense of doom, think massive PE and DO, apply high-flow O2, call a rapid response, and prepare for heparin or TPA.
That is intense. But let's keep riding this vascular train into our next topic, pulmonary hypertension and cor pulmonale. If a PE is a sudden vascular traffic jam, this feels like a slow stiffening over years. It's like trying to pump thick sludge through a cocktail straw.
That analogy is absolutely perfect for the hemodynamics here. The 80-20 overview. Pulmonary hypertension is defined as a mean pulmonary artery pressure greater than 20 millimeters of mercury. This extreme, sustained pressure drastically increases the workload of the right ventricle.
Over years, right?
Over time, that right ventricle enlarges and eventually fails. That specific right-sided heart failure, caused entirely by a respiratory issue, is called cor pulmonale. The most common cause of this entire cascade is severe end-stage COPD.
Let's trace the pathophysiology. I understand the heart failing against high pressure, but why do the pulmonary vessels stiffen in the first place?
It's actually a twisted form of compensation that ruins the system. It starts with chronic hypoxia, usually from COPD destroying the lung tissue over decades. Normally, if a small part of your lung isn't getting oxygen, your pulmonary vessels in that specific area will constrict to shunt blood away to better ventilated areas. It's a smart, localized mechanism.
But with COPD, the entire lung is hypoxic.
Exactly. So the body senses systemic hypoxia and globally constricts all the pulmonary arteries. Over years of this sustained constriction, it triggers smooth muscle proliferation and vascular scarring. The vessels physically remodel. They become incredibly thick, rigid, and narrow.
Which creates massive resistance.
Yes, sustained pulmonary hypertension. Now think about the right ventricle. It is a thin-walled, floppy muscle designed to pump blood into a very low-pressure, highly compliant system. Suddenly, it's pushing against a brick wall of resistance, massive afterload.
So it has to bulk up.
Right. To compensate, the right ventricular muscle hypertrophies, it gets incredibly thick and muscular, but eventually the oxygen demand of that massive muscle outpaces its supply. It decompensates, dilates, and completely fails. That is cor pulmonale.
So the assessment is going to look a lot like heart failure, not just lung failure.
Right. The classic early signs are exertional dyspnea, profound fatigue, and exertional syncope. The heart physically cannot increase cardiac output to meet demand when they walk upstairs, so they pass out. The late danger signs are overt right heart failure.
Because the right ventricle is failing, the blood backs up into the body.
Exactly. It backs up into the systemic venous system. You will see massive distended neck veins. You will see severe pitting peripheral edema in their legs and abdomen. They will have sudden weight gain from retaining fluid and hepatomegaly, an enlarged, congested, painful liver as blood pools in the hepatic veins. You might also hear an S3 or S4 heart sound, indicating a stiff, failing ventricle.
How do we definitively prove the pressure in those vessels is that high?
An ECG will show signs of right ventricular hypertrophy. Their CBC will often show polycythemia.
That's an overproduction of red blood cells, right?
Yes, as the body desperately tries to carry more oxygen to compensate for the chronic hypoxemia. But the definitive gold standard test is a right-sided cardiac catheterization. A cardiologist threads a catheter through a large vein into the right atrium, the right ventricle, and directly into the pulmonary artery to precisely measure the pressures and vascular resistance.
Let's talk medications. We obviously need to dilate those stiff vessels.
Yes, continuous targeted vasodilators are critical to survival. The most famous one is epoprostenol. It is a potent pulmonary vasodilator given via a continuous IV central line pump.
And the source material has a massive glowing red warning attached to epoprostenol. What is the trap here?
The half-life of epoprostenol is mere minutes, literally 3 to 5 minutes. If that IV line gets kinked, if it accidentally gets flushed, or if the pump battery simply dies in the hallway, the drug clears their system almost instantly.
And what happens?
Massive rebound pulmonary vasoconstriction. The vessels snap shut tighter than before. The right heart slams into a brick wall, and the patient goes into immediate lethal cardiogenic shock.
Oh, wow.
You must never allow an abrupt withdrawal of epoprostenol. Always have a backup bag and backup pump at the bedside. We also use endothelin receptor antagonists like bosentan, which you have to monitor closely because it's highly hepatotoxic, and phosphodiesterase inhibitors like sildenafil.
Sildenafil, like Viagra.
Exactly. It relaxes the pulmonary smooth muscle, but you must remember the absolute contraindication. You can never give sildenafil to a patient taking nitroglycerin because the synergistic vasodilation will cause refractory fatal hypertension.
Let's talk priority actions. We have a patient with massive peripheral edema and swollen legs. My nurse brain immediately says, fluid overload, give them Lasix, diurese them.
Proceed with extreme caution. This is one of the biggest intensivist traps in cor pulmonale. Yes, they have systemic fluid overload, but remember Starling's law and that hypertrophied right ventricle?
Yeah.
That right ventricle is now incredibly thick and stiff. It absolutely requires high preload, a high volume and high pressure of returning venous blood just to stretch the muscle fibers enough to generate a contraction.
Oh, wow. So if I aggressively diurese them to fix their swollen ankles.
You drop their preload, that stiff right ventricle doesn't stretch, it fails to pump entirely, and their cardiac output crashes to zero. You fix the edema, but you kill the patient.
That is wild. Treat the cause, not just the symptom.
Exactly. You have to aggressively treat the underlying hypoxia. Long-term low-flow oxygen therapy is vital because hypoxia is the primary trigger for the vasoconstriction. If you fix the hypoxia, the vessels relax slightly, reducing the afterload on the heart. By the time symptoms of pulmonary hypertension actually appear, the pulmonary artery pressure is already 2 to 3 times normal. It's incredibly insidious.
Okay, let's hit our 5-thing summary for the back pressure. Patho is high pulmonary resistance, causing right ventricular hypertrophy and failure. Assessment is dyspnea on exertion progressing to systemic edema and JVD. The complication is severe right-sided heart failure.
Right.
Priority is to relieve the pulmonary vascular resistance and reverse the chronic hypoxia. And the treatment is continuous targeted vasodilators like epoprostenol and low-flow O2.
That's it. If you see JVD, systemic edema, and severe dyspnea in a COPD patient, think cor pulmonale, and DO, optimize their oxygenation to reduce that pulmonary vasoconstriction.
We have reached our final clinical challenge. When the lungs are irreparably scarred by environmental toxins or destroyed by cancer, the medications and chest tubes just aren't enough. We have to cut it out or replace the system entirely. We're moving into the surgical option, cancer and lung transplantation.
The 80-20 overview here focuses on the extremes of respiratory salvage. Lung cancer is the leading cause of cancer deaths, broadly categorized into non-small cell, which grows slower, and small cell, which is incredibly aggressive. On the other hand, end-stage diseases like idiopathic pulmonary fibrosis or COPD may require a transplant. Post-op ICU care is a tightrope walk between infection and rejection.
Let's start with the transplant pathophysiology. How do we differentiate acute rejection from chronic rejection?
Acute cellular rejection usually occurs 5 to 10 days post-op. The recipient's immune system, specifically the T cells, recognizes the new lung tissue as a foreign invader and mounts a massive targeted cellular attack against the graft.
And what's BOS?
Bronchiolitis obliterans syndrome, or BOS, is a form of chronic rejection manifesting as progressive airflow obstruction over months or years. The small airways slowly scar down and close due to chronic inflammation.
What's the assessment? How do I know my patient is failing?
For a lung cancer patient prior to surgery, you are looking for persistent cough, hemoptysis, and hoarseness.
Why hoarseness?
Because the tumor presses on the laryngeal nerve. You know, they are acutely deteriorating if they develop superior vena cava syndrome, where the tumor grows so large it physically compresses the SVC, or if they develop cardiac tamponade from mediastinal involvement.
And for the transplant patient in the ICU.
If they are experiencing acute rejection, they will present with a low-grade fever, extreme fatigue, sudden dyspnea, a new dry cough, and dropping O2 saturations on the monitor.
So what are my ADPI priority actions in the surgical ICU?
Immediately post-op, the priorities are mechanical ventilation weaning, hemodynamic monitoring, and strict hand hygiene to prevent bacterial bronchitis, which is the most common infection.
Because we have intentionally destroyed their immune system.
Precisely. We give them a massive 3-drug immunosuppression regimen, usually a calcineurin inhibitor like tacrolimus, an antimetabolite like mycophenolate mofetil, and high-dose prednisone. We chemically suppress their immune response so they don't reject the new organ.
But in doing so, we leave them completely defenseless.
Exactly. Opportunistic infections are the leading cause of death.
Which brings up a massive differential trap. You just said rejection causes fever, dyspnea, and oxygen desaturation.
Yeah.
But wouldn't a severe bacterial infection cause the exact same symptoms?
Yes. Differentiating between a post-transplant lung infection and acute cellular rejection is notoriously, terrifyingly difficult because the clinical presentation overlaps so much.
So how do I know what I'm treating? Do I just look at the white blood cell count?
You cannot guess, and labs aren't definitive enough. You have to get this right, because the treatments are complete opposites. If the patient actually has a raging bacterial infection, and you mistakenly think it's rejection, and give them massive doses of 5e steroids to suppress their immune system...
The infection runs wild.
Exactly, and kills them in days.
Yeah. And if it actually is rejection, I
Right.
just give them antibiotics.
The immune system continues its attack and completely destroys the newly transplanted lung. Diagnosis requires a transbronchial biopsy. A pulmonologist goes in with a scope, sniffs a piece of the lung tissue, and looks at it under a microscope to see if T cells are attacking it or if bacteria are invading. Once the biopsy confirms acute rejection, the treatment is massive, pulse doses of 5e corticosteroids for 3 days.
Wow. You have to have the tissue to know the truth. Okay, finalizing our 5-thing summary for the surgical option. Patho is the post-transplant immune response attacking the donor tissue acutely or chronically scarring the airways. Assessment is fever, desaturation, and a dry cough post-transplant.
Yes.
The complication is opportunistic infections. Priority is you must differentiate infection from rejection via biopsy. And the treatment is high-dose IV steroids for rejection, alongside strict medication adherence.
Perfect. If you see a patient 1 week post-lung transplant who develops a low-grade fever, a dry cough, and dropping SpO2, think immune system attacking the graft. And DO, prepare for biopsy and high-dose corticosteroid administration.
What an incredible journey through the respiratory system. We have covered the flooded fuel injectors of severe pneumonia, the walled-off necrotic cavities of TB, the crushed and failing bellows of a tension pneumothorax, the sudden blocked fuel lines of a PE, the slow stiffening of cor pulmonale, and the razor's edge of transplant rejection.
And it all comes back to that intensivist framework. Problem, physiology, threat, intervention, reassessment. If you can clearly see the components of the engine and understand the mechanisms of how they fail, you can always find the broken part.
Before we wrap up, I want to leave everyone with one final fascinating thought from the source material. We didn't touch much on it during the cancer segment, but it completely changes how you view a tumor. It's called paraneoplastic syndrome.
Ah, yes. This is where respiratory disease crosses over into systemic endocrine chaos.
Right. We tend to think of lung cancer as a physical mass, just a lump of cells that grows and blocks airways. But some lung cancers, specifically small cell lung cancer, don't just physically take up space. The tumor cells mutate to the point where they physically act like rogue endocrine glands.
They start secreting powerful hormones directly into the bloodstream. They can secrete ADH, antidiuretic hormone, which causes SIADH, leading the body to retain massive amounts of water and plummeting their sodium levels.
Or they can secrete ACTH.
Right, which stimulates the adrenal glands to pump out cortisol, causing severe Cushing syndrome.
The respiratory system doesn't exist in a vacuum. A patient might end up in your ICU with profound confusion and bizarre electrolyte imbalances. You might be looking at their brain or their kidneys. But the culprit isn't their brain or their kidneys. It's a hidden tumor in their lung, pulling the strings of their entire endocrine system.
It really highlights the need to look at the whole clinical picture.
Always connect the dots. The diagnostic landscape is murky, and that X-ray machine might not give you the whole picture. But if you understand the physiology, you can navigate the muddy waters.